In India, 94% of the labor force is the informal sector, meaning thereby you cannot identify the employer-employer relationship. They are on their own. They're employed by somebody on some day and somebody else on the other day. The problem there is defining this individual, because without defining him, you can't benefit him. Then locating him, registering him, and benefiting him. Again, these are very, very difficult jobs. In India, and that would be true of other countries again of this region, is that a lot of us migrate from one place to the other. There is no fixed address. And if there's no fixed address, the technology to be used has to be very different from what technology that we use otherwise. The processes that we use have to be very different from the processes that are used otherwise. The scheme was originally applicable only to the poor. And hence it was essential to find a scheme that was cashless. Because we couldn't have expected this poor man to pay the money upfront to a hospital and claim the amount from the insurance company. It would have killed the scheme. However, the second point was very important. A large number of these beneficiaries were illiterate. And those of you who have had insurance would realize the documentation that takes place in getting an insurance going. Now, how do I expect this illiterate person to understand and sign the documents? Even I don't understand when I sign the insurance document. I don't know how many of you have read the fine print of the insurance document when you sign it. You just sign it. In any case, this guy in the rural areas is petrified of putting his signatures anywhere because he doesn't really know what is in the offing for him. So the scheme had to be paperless. Now this was perhaps the biggest challenge that we faced, because even today, except for this scheme, there is no paperless health insurance scheme anywhere in the world. This had to be a paperless scheme. This was the challenge. We tried to overcome it, and partly we have. And the third point, again very typical of this part of the world, and as I travel to Africa also, they come across similar issues. A person migrates from one place to the other. So the government-related benefit that is available to him in his place of residence is normally not available elsewhere because he is not recognized in another place. He is only recognized in that particular place. So the benefits had to be portable. It provides a social insurance cover of $600. Pre-existing diseases are covered. Then initially we started with only inpatient care. There was a lot of debate about it. Of course, now we are extended to outpatient also gradually. But because of potential moral hazards that have killed most of the health insurance schemes, we started with only inpatient care. It's a cashless coverage for hospitalization. There's a provision of smart card. I'll spend some time on it. There is 1 day pre-hospitalization and 5 day post-hospitalization cover, and there's a small token amount for transport allowance. The premium for the poor is shared between the center and the state government. At each state level, there's a state nodal agency. It prepares the data in a particular pre-designed format. This is very important because that becomes the basic data on which the entire scheme rides. This data is then sent to the federal government. It is run through a software where the internal inconsistencies of the data are sifted out. I can spend an hour on explaining the infirmities of data. In fact, my friend from Cambodia who was making a presentation earlier was pointing out towards it. There are some technology tools available, software tools available, which can help you sift out these. We benefited from that. This data that goes onto the website, it is encrypted data, and only those that are authorized can decrypt this data for use. In the meanwhile, the state government selects an insurance company through a tendering process. The selected insurance company empanels hospitals. Today there are about 12,000 hospitals empaneled in the country, 8,000 of which are in the private sector, 4,000 in the public sector. Then there is a district kiosk that is set up, there's a call center, and this is a very interesting function that happens. We have these smart cards are actually delivered, printed and delivered on the spot in the village. There is no such example anywhere in the world. Most of your debit and credit cards are printed elsewhere and they're delivered to you because you have an address. But these guys don't have an address. If you don't deliver the smart card on the spot, they would probably 50% of them will not reach them. So we do it on the spot. But the identification is done by a government official who's sitting there, who's also given a smart card by us. It's a security card. He puts in his smart card his own thumb impression. The signals from his card flow to the card of the beneficiary. Only then does the card become valid. Of the 35 million smart cards that are in the field, not a single smart card has been given to a wrong person. This is saying a lot in a country like ours. Now, there is no paper being used anywhere. All this is foolproof data flowing right from the data housing to the enrollment and from the enrollment station to a central server. This data is then submitted for paying the premium to the insurance company. In the hospital also, he walks into the hospital, his biometric impressions are matched because there is biometric data available in the chip. Once it is matched, it is also seen the amount left in the chip. The chip carries a credit of $600. So the amount that is left in the chip is also there. The guy gets admitted, he gets his treatment, he walks out, and this data then gets transmitted to the insurance company, which makes the payment electronically to the hospital. No paper used anywhere. And we are able to track each transaction. Sitting in Delhi, I can know which person went to which hospital in which part of the country, how much he has spent, how much is left. That is the extent of data that we are using. This is a typical smart card that we use. The chip that you see here carries the biometric impression of all the family members. It carries a credit of $600 or whatever the value is in terms of the 30,000 rupees that we have in. The photograph of the head of the family is at the white space, and the chip also carries the photograph of the family. Just in case the card doesn't work, the photograph can be used for identification purposes. Now, how is this different? This is probably the biggest use of IT applications in rural settings anywhere in the world. I think the USP of the scheme is the empowerment of the below poverty life. Because in most of the schemes in India, at least in India, they do not have a choice. In this scheme, they have a choice to visit a hospital of their liking. And finally, and probably most importantly, it has provided a physical identity to these people, poor people who didn't have any identity whatsoever.